So welcome to the 10th International PHRI Lectureship. My name is Herzl Gerstein. I'm the current Executive Director of PHRI, and it's great to see a room full of people. It's really wonderful, and it's also good to see Dr. Yusuf here, who's our Emeritus Director, who's now able to join us again after being away for a while. So, and it's my pleasure today just to introduce Noel in a minute, who will introduce our lecturer. And at PHRI, for the purpose of our lecture, we just celebrated our 25th anniversary as a research institute. And as you've seen already, and you will see tomorrow, we are a very robust research institute. And our mission is turning ideas and hypotheses into evidence. And we do that very well, and it's the evidence about outcomes. And most outcomes that are important to people are ones that have been investigated and have been changed by research done at the Population Health Research Institute. And we've had a long list of very impressive speakers, and Dr. Chan will allude to that in his introductory comments. So thank you very much for being here, and thank you all very much for being here. And I'm going to introduce Noel, who will now introduce our speaker. Noel.
Thank you very much. So good evening, everyone. So it's good to see everyone, and on behalf of the organizing committee, I welcome you all to this 10th PHRI International Lectureship. So again, welcome to this 10th PHRI International Lectureship, and it is my pleasure to introduce our speaker, Prof. Wafaei Fawzi. So Professor Fawzi is a physician and distinguished epidemiologist dedicated to advancing global health research, education, and practice. He holds the Richard Saltonstall Professor of Population Sciences at the Harvard T.H. Chan School of Public Health, where he is also a professor of nutrition, epidemiology, and global health. So from 2011 to 2018, Dr. Fawzi served as chair of the Department of Global Health and Population at Harvard. He is the visionary founder and leader of a nutrition and global health program, an interdepartmental initiative at Harvard University that has, for the last 25 years, been instrumental in strengthening the evidence base for improving human health and development. His exceptional contribution to this field has earned him a place as an elected member of the National Academy of Medicine. So Dr. Fawzi has led the conduct of over 30 randomized controlled trials and numerous large observational studies focusing on maternal, child, and adolescent health, as well as infectious disease. His prolific research, published in more than 600 original papers and reviews, has advanced our understanding of the safety and efficacy of integrated nutritional intervention for pregnant women, infants, and adolescents. And additionally, his work explores the complex interrelationship between food system, climate change, and planetary health. As a program director and academic leader, he leads interdisciplinary teams to enhance global health education and advance research and knowledge translation. He also oversees multiple training grants and has developed 2 implementation science initiatives aimed at improving adolescent health in Africa and Asia. His training efforts are dedicated to increase the diversity of global health scientists and nurturing the next generation of public health leaders, particularly in Africa. So with that, I would like you to please join me in welcoming Professor Fawzi for this 10th PHRI lecture.
Thank you so much, Dr. Chan, and it's an honor to be here at McMaster and PHRI, a place that's famous for many things. Certainly McMaster, I went to medical school in Sudan, and even then, many years ago, have heard about the innovative approaches to medical education that have been pioneered here. And a lot of research happening here at PHRI around clinical trials and observational studies in cardiovascular disease, diabetes, and many other conditions. And much of the evidence that Dr. Gerstein has noted translated into policy and impact. And I see giants in the room, Dr. Salim Yusuf. Thanks, Dr. Sonia, for the invitation, and an honor to be with all of you. Thanks to everybody who is online as well. So I'll cover aspects of our work around adolescent nutrition. And there are a number of aspects that I hope to cover in the next 40 minutes or so. And here is a brief outline, a little bit about the issues and focusing on the global syndemic of undernutrition, overweight, and obesity and climate change. And then some of our work, particularly in Sub-Saharan Africa. We engage with partners in India and in other parts of the world, but our focus today perhaps is on Africa, with hopefully some relevance to other parts of the world. And then summarize with sort of key gaps in the way forward. So adolescents are typically thought of as the healthiest part of the life cycle, and they are indeed healthier than the first 1,000 days, where we focus a lot in pregnancy and the first 2 years of life in our work in global nutrition. And increasingly a lot of interest in sort of older individuals, but those who are 10 to 19 tend to be neglected, and that's where we have sought to sort of engage and focus a little bit more over the past 10 years. It's about 1.3 billion people in the world who are adolescents, and their health and well-being is really central to creating a sustainable future for their countries and for the world. In Africa, population growth is happening, continues to expand. By 2050, 1 out of every 4 individuals in the world are expected to be African. And a large part of these are adolescents and young people. So the focus for us has been to try to understand the health and well-being of adolescents in Africa, given that potential that they have, and given that a lot of the risk factors that happen during that sort of period of time has relevance for their health at that time, their health later on in life, sort of whether it's physical activity, dietary intake, mental health, drug use, and others, but also have implications for the families that they sort of bring into the world at a later time. If one thinks about the sort of burden of disease among adolescents, there are about 1.1 million deaths that happen in this age period. And the rate of mortality is going down in all regions, but as you can see, that tends to be twice as high in Sub-Saharan Africa compared to other parts of the world. If one thinks about what the causes of death and disability-adjusted life years are, among those who are 15 to 19 and 10 to 14, nutrition seems to be an important, among the top 5, particularly iron deficiency anemia, an important cause of sort of morbidity and mortality. But other causes are important, particularly mental health, anxiety, and depression are high. Maternal conditions, particularly among those who are older adolescents, adolescent females. And if one looks at males, similarly, depression and anxiety are important causes of days lost. But nutrition is also a big, important element. And thinking about sort of where these elements of nutrition come to play in sort of adolescents and young people, including children 5 to 19, we know that in much of Sub-Saharan Africa, underweight is still a big problem. There has been a significant improvement over time, but there has also been a rise in overweight and obesity among these parts of the population, both boys and girls. And one thinks about sort of this double burden sometimes, as we refer to it, both underweight and overweight and obesity that happen at times within the same household. So there might be an overweight or obese mother and an undernourished child, undernourished suffering from anemia, from various micronutrient deficiencies. Sometimes it's in the same individual. And at times we refer to sort of overweight mothers who are also anemic and suffering from these multiple ailments at the same time. And we start thinking about how these coexist with climate change that is really a major sort of phenomenon that's affecting all parts of the world. And how these interact really with each other, these triple elements of underweight, overweight, and climate change as part of this syndemic. So these are three pandemics that are existing at the same time and place. They are interacting with each other, and they are having common risk factors. And so one can think of how climate change is responsible for droughts and excessive rains that leads to food insecurity and poor quality of diet that is the underlying factor for overweight and obesity and undernutrition and its consequences at the same time. So the interest in adolescence and these sort of syndemics has been highlighted more recently over the past sort of 10 years or so. An increasing attention to the role of adolescents in the lifetime experiences of individuals has come to bear, influenced by the Lancet Adolescent Health Commission, by a lot of efforts from WHO. There is this document that was developed by WHO, the Global Accelerated Action for the Health of Adolescents, or AHA as it is referred to sometimes, essentially trying to identify the various risk factors that are common to both underweight and overweight, and the interventions that need to be pursued as part of this next agenda. There are key barriers really that one can think of when it comes to considering how to advance the health of adolescents and their nutritional status. And one aspect that I'll focus on today is sort of the work around data availability and evidence around that. There are other barriers, as you can see, and I'll come back a little bit later to the role of sort of training and capacity building in these settings. In our efforts, we have tried to advance an agenda as a network. We work with partners in 10 countries in Sub-Saharan Africa that are noted here on the screen. Essentially, in every country, we have a partnership with one or two universities. So University of Ibadan in Nigeria, University of Ghana in Ghana, Makerere in Uganda, WITS and University of Cape Town and University of KwaZulu-Natal in South Africa, and others. And through these partnerships with academic partners and colleagues, we engage with communities and with policymakers. So the ARISE network, as we call it, Africa Research, Implementation, Science, and Education, has these three pillars of effort: capacity building, cutting-edge research, and sustainable partnerships. And we focus on a number of elements when it comes to research and capacity building, but adolescent health, food systems, and climate change are sort of common aspects that we have tried to advance as a group. And we do that through these three pillars of work that we try to advance. Evidence synthesis through systematic reviews and meta-analysis, observational studies, and intervention studies. And I'll talk briefly about our work in each of these, and then in my concluding remarks, bring back the element of training and capacity building. So with respect to evidence synthesis, we've completed a number of systematic reviews, one around the importance of school feeding programs, others around the double burden of malnutrition and the double duty interventions, and a series of various systematic reviews that I won't go over each one of them. Just a few words on the first one around school meals, because that's really an aspect that is gaining traction in many African settings. A number of studies have been carried out about the value of introducing a midday meal in Africa. And this is really the global evidence around low and middle income settings. There are 44 RCTs and 13 before and after studies that were introduced. And overall, wherever it was possible, and the data is sparse and not well documented, and there are limitations to the design. So just a brief highlight of the main takeaways. Whenever there was at least 3 studies that provided the outcome, we sort of meta-analyzed that and pooled that estimate. So when it comes to height in centimeters, schools or children in schools who provided a midday meal or a snack had better height compared to children who did not benefit from that. But when you look at that as a height for age Z-score, the effect was much more modest and really not significant. Similarly, when it comes to weight, there was about 570 grams higher weight among children who benefited from a meal or a snack in school compared to those who didn't. And when you look at that as a Z-score, weight for age, the impact was not evident. There was a modest benefit when it came to impact on attendance in school. And that's one of the main attractive elements of meals, is that many adolescents tend to have that as really the only meal that they have. They arrive hungry and they are unable to continue and concentrate in school. So it has multiple uses. But one of the challenges is that the evidence, even though it is extensive, it's not well done, and increasingly a number of groups are coming together to try to enhance the quality of the meal, enhance the design of those programs, the data that is collected, the approach to sort of assessing the impact, both with respect to effectiveness on school attendance, on school performance, on development, and the cost effectiveness of these approaches. So it is a promising area, but has a lot more gaps at the moment, and a promising area to pursue. On the various other systematic reviews, really just some key lessons that I'll share. One from the multiple systematic reviews is that integrated approaches are better. So instead of focusing only on one approach, supplementation or curriculum development, or water, sanitation, and hygiene, integrating these leads to greater effectiveness. Perhaps it's more commonsensical, but that's not always done. Many times they are really siloed interventions. There are multiple delivery platforms that can be pursued in reaching adolescents. Schools is definitely one. Community settings where there are community health workers or demographic health surveillance systems that might be used as a launching pad for reaching households with adolescents. Duration is important. Sometimes if one wants to have an impact on obesity prevention or obesity management or undernutrition, a shorter intervention is unlikely to be impactful, and so a longer duration is needed. And monitoring and evaluation is critical, of course, to be able to document that evidence and be able to make it available to policymakers. There are various gaps. One that's notable is that we typically focus only on undernutrition or overweight when they are really having many common drivers. Thinking about various platforms, as I mentioned, is also important. Engaging with other sectors beyond the school, the health sector, the agriculture sector to enhance food security is something that is increasingly being considered, and I'll share an idea that we are trying to explore. And then engaging multiple stakeholders, that it is not just the adolescent, but also the teacher and the parent and the headmaster and the food vendors that are in the vicinity of schools that are important contributors to this area. So that was really helpful to have an understanding of the evidence in the literature before we were able to sort of identify where the gaps are and how we could contribute. And we try to do that through additional data collection. Much of it is lacking in Sub-Saharan Africa, and then before long, advance to intervention studies as well. In terms of observational studies, our efforts have been mainly, so the first two are cross-sectional studies, and the third, an effort to move to a longitudinal observational effort. Much of it is also used as an opportunity to collect data and to train the next generation of leaders. So they have led the analysis and the publication of many of these findings in the various supplements and individual papers that we have. But some of the key findings on the community-based study was a cross-sectional study, our very first effort in that regard, published in the year 2000. So these were part of community-based platforms, health and demographic surveillance systems that you might be familiar with, typically about 100,000 individuals who are followed up regularly over time, maybe 20,000 households. And so we graphed our efforts within those surveillance systems and sample households that have adolescents and then assess their sort of state of health and nutrition. Just a few findings quickly. Fruits and vegetables are very low in intake, inadequate consumption of fruits. So if you look at males or females, those who are 10 to 14 years of age, inadequate consumption, less than 1 per day. Some variability between the various countries that you see them down in the rows. Same if you look at 15 to 19, fruit consumption is quite inadequate. Vegetable consumption also quite inadequate in both 10 to 14 and 15 to 19. So the diet tends to be mostly monotonous, sort of staple food, bananas or rice or bread or sort of starch that is devoid of animal sources and sort of micronutrient and protein, essential fatty acids. While that is the case, there is also, unfortunately, a rise in consumption of sugar-sweetened beverages and processed foods, and sort of an overall sort of inadequate and suboptimal quality that is driving both the continued and persistence of undernutrition and the rise in overweight and obesity. Coupled with limited physical activity, less than 1 hour physical activity per day among those who are 10 to 15, and 15 to 19, about 70 to 80% have minimal physical activity according to this indicator. So that collectively contributes to the rise in sort of NCDs in this age group. Beyond the community setting, another platform that we have begun to develop a closer relationship with is the school system. School platforms are important. Students come to school, and even though not everybody in school, that attention or enrollment in school is on the rise in many countries in Africa. So 60 to 70% would be, or even higher in some places, at least in primary school. And it is on the rise also for secondary school, more in urban than rural, but certainly a large number of adolescents are reachable through schools. So we looked at the same set of questions, but with other sort of vantage point of using the school as a platform also for interventions as we advance. Anemia is a problem in some settings more than others. It's about 30 or 40% in a country like Burkina Faso. It's about 50 or 60% in parts of East Africa, including Tanzania. And a lot of it, at least 50% of that, is iron deficiency anemia. If one thinks about the school as a platform for interventions, we sought to understand the school environment, sort of variable school facilities that might be conducive for advancing the health and well-being of adolescents. So more than 70% have toilets and hand washing stations, and toilets by gender. or piped water, which is ideally should be much more than that. Universal would be nice. But certainly even much less when it comes to other interventions around a school clinic, a food storage facility, a school garden, and so on. And if one thinks about vendors really as an important sort of risk factor or predictor of access to healthy or unhealthy food, quite a bit, if one looks just at the total across these 5 countries, a large number of vendors, typically within the school or in the sort of vicinity of the school, tend to offer sort of processed foods and very much less sort of fresh fruits and vegetables and animal products. Partly it is because they taste better and that's what the students want, and partly because they are cheaper and more affordable than fruits and vegetables. So it's a complex sort of story to think about how to enhance the environment in a way that is affordable and effective. If one looks at school curriculum as an approach to enhance the education of adolescents by enhancing the school curriculum, it's being considered in some places, but not really as sort of adequate, but also policies and at times, even when there is a written policy, it may not be actually adhered. So it tends to be sort of a policy document on paper without actual implementation of that. So moving from a snapshot assessments cross-sectionally to a longitudinal aspect, in the first 2 studies, we sort of had a very long questionnaire of about 400 variables. This is coming from the school GSHS, this Global School Health Survey. And trying to do that longitudinally, we thought that it would be important at least to start with reducing those indicators. So we went through a systematic approach and have reported that in the literature, essentially to find out what are the key domains that we would focus on. Nutrition is one, mental health, health facilities, utilization, drug use. These were sort of some of the key domains that we decided to hone in on. And within each one of them, we really engaged with experts in that domain to understand what would be the shortest possible set of questions that assess anxiety and depression or diet or sort of other elements of the domains we are interested in. And we came up with a tool that we implemented at 2 surveys and are sort of examining that sort of data. But we used the time between the 2 surveys to develop a way to sort of connect digitally with adolescents. That's another sort of platform that is increasingly an opportunity to reach adolescents through cell phones where it is possible. And happy to think about this and discuss it and hear your perspective and experience as well. It is a challenge. Not everybody has access to an iPhone, and so we might have to, a large majority have access to a sort of a flip phone, a regular phone. So that limits the engagement to text messages, which have to be very short and not as sort of interactive as smartphones. And so one of the approaches that we are considering in that regard is sort of more centralized sort of places of engaging adolescents with a central facility that has a smartphone or a tablet, internet access, reliable electricity, and an opportunity for peers to come together to learn from one another and hopefully bypass those challenges that tend to be also more challenging to girls compared to boys. Some of the analysis that we have done with the first cross-section out of the 2 surveys is just one example here to look at the clustering of risk factors among adolescents. And indeed, there are such clustering. So in this analysis led by a colleague, there are 3 clusters, one group of adolescents that are particularly sort of affected by alcohol and risky sexual behavior, and other 2 clusters sort of highlighting that many times risk factors go together. And as we think about interventions, much like the findings from our systematic reviews, sort of engaging in an integrated approach is something that is important as opposed to one risk factor at a time. If I could transition to some of our findings from intervention studies. And that's all along our target is to really do more interventions because we would like to see impact and hopefully learn and scale up. So we have 6 or 7 studies, and I won't go into detail about each one of them, but I'll mention a little bit about each. Essentially, one is the MEGA study. It's kind of a small proof of principle study that has 3 interventions: meals, education, and gardens for in-school adolescents. This is in Dodoma, Tanzania, the capital of Tanzania, sort of the real capital as opposed to Dar es Salaam, which is the commercial capital. An approach that seeks to, in 6 schools, 2 control schools, 2 schools that receive the full package of interventions, including a midday meal, 2 interventions, 2 schools that receive a partial, and 2 controls. And the partial don't receive the midday meal. Essentially, the meal was local foods prepared by a cook on the school premises. And there are various models in the world. Visited Akshaya Patra in Bangalore, which is really quite sophisticated, centralized meals that are distributed to the whole city. It's hard to replicate that in a setting like this. So these were cooks on the premises. School garden, where it was really an opportunity to engage with gardening and learn about nutrition, but also use that as a resource for the midday meal. Some of the food that's harvested. Enhancing the curriculum in ways that improve understanding of nutrition and engaging with teachers around that. And really also using the school as a place for the community, the parents to come, and the school garden as a model farm where they can learn about extension services and hopefully take that to their homestead gardening as well. Simple study, 6 schools, some promising findings that there is an improvement in diet quality measured by the Global Diet Quality Score. Some improvement in weight and BMI for age, whether it's partial or full intervention compared to the control. And for parents who came at least once a month, they have also benefited in some regard with respect to diet quality. There are limitations. It was short. It was only 6 studies. And really, there was no impact on anemia, which is an important endpoint that we were hoping to examine. Hopefully, in our next study that we are in the process of doing, we will have a longer duration and a more hopefully impactful and larger study. Our second study is looking particularly at anemia, and a large part of it is iron deficiency anemia. And so we looked at two countries, 2 trials. In both of them, they are identically powered, 42 schools in each country. But there were 3 arms. 14 schools received standard of care. 14 schools received a weekly iron and folic acid. and 14 schools received a multiple micronutrient supplement. And the IFA and the MMS are the same tablets that are typically available in the healthcare system because they are part of antenatal care. So the MMS, as we know it, is 15 micronutrients and single RDA, including IFA, given daily. And the IFA arm was just 60 milligrams and 2,800 micrograms of folate. That's the adolescent version of IFA. But the impact is likely more so driven by iron than by folate. In two trials, one in Burkina Faso and one in Tanzania, just a slide about each. In Burkina, neither of the interventions had a very clear benefit, a weak impact on moderate to severe anemia with IFA. With MMS, a stronger impact, a relative risk of 0.35 compared to 0.78, with a borderline impact, but not significant statistically. In Tanzania, this was in Zanzibar, the main island. Also no impact of IFA when given once a week. And this is the recommendation of WHO to give weekly IFA to adolescents. But MMS did have a significant reduction in moderate to severe anemia by about 35%. From the SAMIA trial, some takeaways. Essentially, there are potential differences between settings. In Burkina, there are other factors. Malaria is a big issue. Deworming was important to include because there is a higher infestation of GI helminths. And we haven't really sort of focused on that. We, again, siloed only on the supplements as we shouldn't have. So integrating approaches to addressing malaria and deworming is important in that setting. And then thinking about sort of MMS, which is has a daily supplement of 30 milligrams of iron compared to a once a week 60 milligrams of iron, whether that's the reason why MMS was more effective, potentially. But MMS also has multiple other nutrients that are contributing to the risk of anemia. Trying to move to a more integrated and a broader set of efforts in Tanzania. I'll say just a few words on this sort of design and evaluation of a school integrated approach. Essentially engaged with adolescents, parents, teachers, vendors in a human-centered design approach to develop sort of inspiration, ideation, and ultimately testing of a prototype, various focus group discussions and workshops with the various stakeholders, and came up with, based on this feedback, with a multi-track approach that engages with adolescents at a whole school level, at an individual level, and sorry, I can't see it myself. The whole school intervention, having a school committee, a school assembly that sort of meets once a day and provides an opportunity to disseminate messages, a health and nutrition policy that the school develops and adopts, a wall magazine that engages the whole student body and teachers, and a health and nutrition day was what was deemed by the collective group of stakeholders as a way to go. At the group level, which is at the level of adolescents themselves, this is within the context of the classroom, improve physical activity, improve the curriculum, provide an opportunity to engage with students through a club that enhances their own knowledge and understanding, engage with them through SMS messages. And then lastly, at the individual level, for those who are suffering from a particular issue, undernutrition or overweight or need tailored sort of intervention to that particular person, that is a forum that ultimately, hopefully, will have an impact on these primary and secondary outcomes that are noted here. Another approach that we're beginning to advance in Ethiopia is again, still focusing on schools and enhancing school feeding and education through the curriculum and engaging with teachers and adolescents, but really bringing in the climate aspect as well. And so it's still at the beginning, just recently funded as a small sort of opportunity with funds from Harvard opportunity, engaging with farmers and developing farmer cooperatives in a way that advances climate smart agriculture. So seed that are resistant to drought, various agronomic practices of adaptation and mitigation that enhance the quantity and quality of food that is then sort of secured from these farmer cooperatives to be supplied to the school, to be part of the school feeding program. And that, on the one hand, enhances the education and nutritional availability to adolescents, but also the livelihood of the farmers that are sort of locally sourcing this food, and ultimately, hopefully, has an impact not only on the well-being of adolescents, but of their families and of the community at large. So integrating these across the three elements of this endemic is what we aspire to show. And in beginning discussions with partners in Ethiopia and the government of Ethiopia, the hope is to use this entry as an opportunity to do it on a larger number of schools than what we have at the moment the ability to do. One slide on two large platforms that we have in ARISE. There are 8,400 adolescents in a study called Nutrient, and 14,000 in another study, essentially providing these regular assessments once a year. And our hope really is to think of a way to enhance this as a long-term follow-up of adolescents, and inspired by PURE and many of the other longitudinal studies that you have here, a way to have a long-term follow-up of adolescents into adulthood and beyond, if we are able to do that. Just a few words on, this is the same slide on the key gaps, and one of the key gaps is data availability. But the second that I want to touch on is capacity to do research. There is an improvement over time in the various outcomes. Undernutrition is reducing, mortality is reducing, but overweight and obesity is a higher proportion of the burden of disease in many countries in Africa. While only 4% of the global workforce is in Africa, with about 25% of the GBD, global GBD, DALYs is in Africa. So there is a massive shortage of trained workforce. One training grant that we have is this one that's supported by the Fogarty International Center at NIH, essentially to enhance the capacity of harnessing and harmonizing data and data science to examine key priorities, multiple sites in Sub-Saharan Africa. Ultimately, using UKZN University of KwaZulu-Natal in South Africa as a hub with spokes in other countries in Africa, in partnership with Harvard and Heidelberg in Germany, and build capacity over the past 4 years in short courses, in fellowships, but culminate in the last year with a master's in health data science that enables not only sort of strengthening methods, but also the application of methods. And one of the domains we are focusing on is the application of methods to this syndemic question. And recognizing that there is a lot of data for food insecurity, for climate, for health, that can be brought together to answer important questions and enable prediction of next steps with appropriate skills. I will perhaps end on one slide. We have done a survey of all schools of public health in Africa, Sub-Saharan and North Africa, and the issue was to understand what is the limitation in schools of public health. And there are a number of limitations, and a paper has been published that essentially notes some of these recommendations, essentially to enhance competency-based education, to enhance the infrastructure that enables communication with across countries. But one of the key findings also is to strengthen interprofessional education and linkages with other sectors. So seeing the university in the middle as part of an ecosystem that links with the research system, research institutions where trials are happening and more discovery work, as well as the health system on the left, ministries of health and national CDCs, and a lot of synergy between give and take. There are advantages instead of the current siloed framework that is typically in many settings. And closing the gap, my last slide are some points that are here with respect to adolescent health. Prioritizing adolescents and engaging with them as and their voice is important. Strengthening data systems to collect data and be able to have the capacity to analyze it. Do that as a partnership between universities as a region and in partnership with the North when it is helpful, but also within the region, engaging the ecosystem as a whole and empowering adolescents, as I mentioned before. And we are fortunate to have a wonderful set of partners in Africa and beyond, and a number of donors that we are grateful for. Thank you so much for coming.
So I think it's now time for question time. So we've got 10 minutes, perhaps 3 or 4 questions. Is there anyone?
Decided I won't go at all.
Well, thank you so much, Wafaei, for that presentation and all of the work you've done. You go by the slides quickly, but each project probably took a number of years to get underway. So that's amazing. I have a couple questions. The first is you mentioned adolescents, a tough group, no matter which country in which you live. Are you doing co-design with the adolescents? It kind of seems obvious to us all now that we should do that, but 10 years ago, 20 years ago, we usually thought of the logical intervention ourselves as academics and then tested it. Are you doing co-design would be question one. And the second one is with respect to WhatsApp and data collection using smartphones and WhatsApp in a secure manner.
Yeah, we are seeking to engage with adolescents more recently, and we have been in the same school that we have figured it out what is best for the people and developed the trial and discovered that it's better to, particularly for adolescents, to engage intently. So we are engaging with adolescents in sort of a co-design effort. What the problems they see, what the solutions are, how to package them, what platform to use, how to reach them, how to engage with other stakeholders. So that is increasingly our approach, and it's an important point that you have raised that. With respect to data collection, we haven't developed that aspect yet, really. Our focus, and we should, and I'd love to learn from you where you are on that. It's it's challenging. Our focus has been more on when we developed the short tour is to be able to ask that on a digital medium, and rather than sort of go to the homes like we have done in the 2 surveys. There are lots of challenges really around access to smartphones. So very few have a phone. We asked, does your parent or somebody in the home has a phone, and the percentage goes up. But if we ask the question through that sort of it goes from 40%, let's say, to 70%, it's unclear. We haven't tried that really, whether the parent will actually deliver the communication to the adolescents if it's an intervention, or answer the question accurately. And if it is a sensitive issue, it might not be the right way to go through the parent anyway. So it's challenging in many settings. I think ultimately there will be access to handheld iPhones by most people. The prices are going down, even in certain settings in India and China, but for African youth as well. For now, our track is really to centralize that service where they could come, perhaps answer a question and access some videos and develop some material themselves in a way that is peer-driven. But it might be hard to do it at the individual level at their own home.
Thank you. Then
Thanks very, very much. I'm struck by the prevalence of iron deficiency and that you talked about, and I'm thinking back of other things in the West when there were other nutrient deficiencies, and like one, for instance, in the West 100 years ago, when there was pretty profound iodine deficiency, it was solved not by giving people supplements, but by fortifying foods with iodine across many Western countries. So is it possible to fortify, to have a staple that's eaten by everybody and fortify it with iron, and then have it manufactured in a cheap way that it becomes ubiquitous? I mean, iodine deficiency was solved by fortifying salt, so that it was not an issue anymore. So can you do the same thing with iron and things of that nature? I don't know, and I'm just asking the question.
No, it's a very good point, and it's something that there is a lot of effort in that regard. There is fortification of wheat and fortification of sugar for vitamin A or for iron, or salt, which is also a very ubiquitous. It's challenging. It has its own challenges. It needs certain centralized places where such fortification and access to the food, they tend to be a little bit more expensive. And there are efforts really that have been successful, but there are also efforts around biofortification, where enhancing the iron content of beans, so that the bean that's on the market is orange sweet potatoes, enhancing the vitamin A content of sweet potatoes. So there are such efforts, and the sense in the field really is that these probably need to be complemented with other approaches as well. So integrating supplementation with fortification and education are together likely to be enablers of solving the problem of folate for pregnancy, or iron deficiency, or other nutrients.
Hi, thank you so much for this lecture. It's amazing. Just I would like to ask you about, you can give us more details about the research methodology that you used before these two studies?
So can you say that again?
The research methodology that designed for this research, or these two studies for these countries.
Yeah. The research methodology for the various studies, they are published. So I'd be happy to share. So, for example, the one where we have shortened the questionnaire and come up with the method for that, and the questionnaire itself is an appendix to the paper. The methods for the other ongoing studies are also published as design papers. So if we communicate on email, I'd be happy to send you anything you want.
Thank you. 4 more questions. So I think we've got Dr. Yusuf.
That was interesting. You've opened my mind to a whole new age group. Two related questions. Sorry. Absolutely. Good thing at my stage is I think in ideate. You guys have to do it. Right. I'm curious how you decided and what your nutrition component should be. Like the pictures you showed, the food meal was largely starch and cereal, and there was a few beans. I didn't see an egg, I didn't see milk, I didn't see a bit of chicken or fish or anything. So maybe my eyesight is failing me. Yeah, that's the beans, that's the thing, and that's a big dollop of things. Has this actually been shown to have an impact in a small study on just iron levels in people, hemoglobin levels in people? That's one. The second is, even if you correct iron alone, I'm going back to my experience as an intern 45, 50 years back in rural India, hookworms was a major issue. Infections was a major issue. Now, in a randomized trial, you can say they randomize out, but had you considered how these factors will have an effect?
Yeah, no, these are very important points. On the first one, there is a little bit of vegetables, but you're right. It could be sort of richer, and beans and some vegetables, and this is exactly carbohydrates, ugali. An egg would be good. Some protein that's animal source would be good. And perhaps in our next iteration, we would try to do that. And the challenge partly is it's not a good reason not to do it, but how to identify an affordable meal that is still nutritionally rich and dense. And perhaps an egg would certainly be affordable. A chicken might be harder, sort of meat might be harder to do. So certainly, as we advance there, that's important. With respect to the second one, in the Burkina Faso study, it was nutrients, and the impact was the IFA arm and the MMS arm, and there was no impact on anemia. Largely, potentially, is because we hadn't factored in deworming, even though it was evened out. The impact was weaker because it wasn't it's not a confounder, but it's still not. That's part of the explanation why the impact potentially wasn't there. So thinking about an integrated approach that deals with anti-malarials or prevention of malaria, bed nets, etc., in a setting like Burkina, with deworming, in addition to nutritional supplements, is an important package.
You consider deworming?
We are in the future. We haven't done it in the past, and the reasoning was, and that was probably an afterthought, the government said we do that, but we should have sort of assessed whether it was indeed done. And the sense is probably it wasn't done. So in the future, we would integrate it and make sure that it is actively part of the package.
So I think we'll have time just for two quick questions.
Yep.
So I'd like to finish by 6:05. So John and then Shrikant after that.
So thank you very much. Wonderful presentation. So many questions in Africa. And it seems to me that the big challenge is finding a question with which, when you find the answer, you can actually implement change. And that is obviously hugely difficult because you need a lot of resources to implement change. Coming back to the iron deficiency story, it's rampant, and your trials show that iron replacement was effective. At least I'm sure that they would be effective if you had a slightly larger trial. But how do you take that forward? Is it possible to introduce iron supplementation, which is incredibly cheap? Can you think us through this challenge of implementing the results of randomized trials in Africa to improve nutrition in adolescents?
it's a problem. Thank you, and excited that you are doing more work in Africa now. So, but it's a challenge for many or most or all interventions, really, how to translate findings from research into practice. And one of the approaches that we are trying to advance is to sort of think about this ecosystem. And so this is the outcome of a review of various schools of public health and their environments, the instructional elements of the school. This was about doctoral program in public health, the institutional needs as far as faculty, staff, but also the external elements, which include sort of other parts of the ecosystem and other parts of the interprofessional community. And so part of the solution, I think, or a large part of the solution is thinking that questions are developed in partnership with policymakers so that it is not done in isolation. Analysis and findings are reported back in a way that is reasonable, not through a Lancet paper, but through policy briefs and engagement with them in ways that would be sort of comprehensible and they have time for. But also sort of building the capacity of the health workforce so that they see the value of research as well. And so in our training, we tend to focus a lot more on research training and less on practice training. In our PhDs, it's more a research doctorate rather than a practice doctorate. So there is an effort as part of this finding to translate some of these recommendations that I mentioned earlier into a reality. We are working with 5 countries to see that schools of public health enhance their training in partnership with other parts of the ecosystem and address key challenges. And we'll focus on 2 or 3 issues, perhaps NCDs, perhaps mental health included, perhaps food security and nutrition, in a way that sources questions and feeds back interventions into programs at the same time as the ministry would want it to be available.
Last question, Shrikant.
So thank you for excellent presentation and raising the fact that you have to have so many complex factors that are going to be affecting things so that you have interventions that are complex and there are multiple factors that are part of those interventions. So yes, when you have something that works at the end, how would you tackle finding out which component of those multifaceted interventions actually is the one that is driving the results, or which parts are more cost-effective or less cost-effective, or which ones give you the better benefit? How do you tease that out once you find out something that works in a multi-component intervention?
I would come to the statisticians.
Exactly. You should know, right?
So, yeah, no, that's an important question because it might be complex, and finding a simpler version while maintaining the effectiveness and perhaps reducing the cost would go further along. So I imagine some data collection on fidelity to various elements or components of the package would be important. And it becomes more an observational, but sort of with appropriate analysis and expertise from statisticians, one can get to that a little bit. But I'd love to hear if you have other ideas. Thanks.
So, thank you very much for this excellent talk. So.